Been a lot of discussion about the Gwent area having a very high number of coronavirus cases. What does that look like from your perspective as an intensive care consultant? What's it like in there right now?
We are definitely seeing a large number of cases. As I've spoken to colleagues up and down the M4, and I think we are definitely ahead by a week or two in terms of the rest of the M4 corridor in cases that we're seeing. We've actually filled our intensive care unit now above our normal capacity. So usually we have 13 ventilated patients, or what they call level 3 patients, so patients who need maximal organ support. And that's our usual maximum number that we can take. So we've got 16 ventilated patients in the intensive care unit at the minute, which has led us to completely run out of space. So we've taken over theatre recovery, and we've got a further 8 there. I think by the end of today we will fill recovery, so that will bring us up to 25 patients. And then we have another area prepared, which is the old high dependency unit in coronary care that we've taken over as well. And we can fit a further 22 patients in that area. The way things are going at the minute, the rate of growth and the amount of admissions that we're seeing, I would say we will fill that by the end of the week probably.
By the end of the week?
So we're looking at, by the end of the week, we probably will have quadrupled our capacity here.
And then what happens?
And then we'll have to find somewhere else to, at the moment we're trying to identify other areas that we can put patients.
Can you paint a picture, if you like, of what it's like right now inside your critical care unit? If I was to walk in, what would I see? What would I hear?
It's controlled chaos at the moment, just in that space is a premium. All of the normally our patient population is made up of people who are acutely unwell, who are on ventilators, kidney machines, strong drugs to support the blood pressure. There'll always be a few of them. There'll be a few people who are recovering, getting ready to leave the intensive care unit, and then there'll be a few patients who just need a bit of supportive care, who maybe aren't as sick as the others. The difference at the moment is everybody is desperately unwell, everybody is on a ventilator. So the acuity or the severity of illness that we're seeing is very high. The staff are all wearing full PPE, so what I'm wearing now, but with this gown the other way around, plus goggles, plus respirator masks or FP3 masks, and 2 pairs of gloves. It's very hard to identify which staff members are which, so we've taken to writing our names and roles onto the front of the gown so that we can easily identify people.
How would you describe the atmosphere right now?
The atmosphere is, we're doing what we're best at doing. So morale is high, there's a great deal of camaraderie. Everybody is aware of the severity of the situation, and I think everybody is focused at the minute on delivering the best care that we possibly can to these patients. They are the patient population. There are a lot of people who are in work. There are a lot of people who are younger. It's certainly the pattern of illness that we've seen in Gwent, and I can't speak for anywhere else, is much younger patients than we were expecting. You know, when the reports started coming out of Wuhan, we were led to believe that this was something that was particularly dangerous for the more elderly patients, but I would say all the patients that we've got in intensive care are in their 50s or younger at the moment.
Really?
Yeah.
I think that would surprise quite a lot of people.
And it surprised us. Our youngest patient is in her early 20s. And there are patients who are very well. You know, a chap who's a fitness professional. That, you know, there are a lot of patients who do not have any pre-existing medical conditions. They're not diabetic or anything like that.
If it's difficult sometimes to identify your colleagues in the unit, presumably there is a real challenge of communicating with patients as well.
Yeah, and that's probably the biggest challenge that we've found so far. The patients themselves, on the whole, are unconscious. We anaesthetise most people on ventilators just because it's very unpleasant having a foot-long plastic tube through your mouth, down the back of your tongue, and into your upper airway. So most people will need some degree of sedation to tolerate that. It also means that they will synchronise better with the ventilators. They're not fighting the ventilators. They'll allow the ventilators to do their job. So the vast majority of the patients are fast asleep at the moment, mainly for their comfort and also to facilitate their care.
Can you have any visitors
No.
in the unit at the moment?
Not at the moment. Logistically, it just isn't possible at the moment, and that's partly for public safety.
And how difficult is that for everyone involved, given that some of these patients will be perhaps, close to their last days.
It's incredibly difficult. We are updating people as much as we can. We've got dedicated people who are phoning and updating relatives every day. We're also using email, and we're able to use video calling. But it's a poor facsimile of actually sitting down in a room with proper human contact to be able to give someone a hug, or offer them a hand if they're upset.
Can I ask you,
yeah.
if you have a patient who is in an end-of-life situation, can the family come into the unit?
Thankfully, we haven't been in that situation much yet. We are looking at potentially finding a way to allow family members to come in accepting the risk and wearing full PPE. I mean, it's the last thing we want to deny anyone time with their family member if they're going to die. But the practicalities of that we haven't ironed out yet. The danger is that then, particularly if you've got more elderly patients who have succumbed to the disease, if their relatives are of similar age, which they often are, wives, spouses, etc., there's a real and tangible risk that if the disease is transmitted to them, that they could end up in the same situation. So,
have you had patients dying in the unit from coronavirus?
Yes.
Can you explain to me why someone can die after having contracted coronavirus?
What we know is that primarily the coronavirus causes respiratory failure. So when it spreads to the lungs, it causes what we call a pneumonitis, where the lungs become very wet and waterlogged inside. So the normal mechanisms that keep fluid in the blood break down. So the little membranes and tissues in the bases of the lungs become porous, and that allows fluid to leak in from the circulation into the lungs, almost like drowning. One of the things we provide with the ventilators is we can provide pressure which pushes some of that fluid out and helps to keep the lungs open. So one of the mechanisms that people become exhausted is because the work of breathing is so great that they basically become exhausted and die. So if you imagine your lungs are normally like a nice light sponge, light and easy to move. If you've ever pulled a sponge out of a bucket of water, you know how heavy and wet a sponge can become. It's exactly the same thing. If your lungs are absolutely sodden, then it's very, very difficult to breathe. And what happens over time is people's oxygen levels fall, the levels of carbon dioxide, which is a gas you normally breathe out, rise in the blood. That makes you even more drowsy. It has a narcotic effect. And then people will slowly develop worsening respiratory failure, and eventually they'll become unconscious and their breathing will get more shallow and they will die. So that's what would happen if you were left alone. Thankfully, we can intervene with a ventilator and prevent that from happening. But the deaths vary from multi-organ failure, which is basically a progressive shutdown of all the different organs, including your kidneys, your circulation, failure of your liver, as well as your lungs. So we've seen that. But we also see patients who develop a thing called a myocarditis lately. Often when they're starting to recover, the heart can become very adversely affected by the virus, and they develop heart failure. And that's been probably the leading cause of death in the COVID patients that we've seen.
You had coronavirus. What was that experience like?
Not one I'd like to repeat. Started off quite innocuously. I had a bit of a burning sensation in my nose. I lost the ability to smell, even though my nose was clear. It wasn't bunged up. I didn't feel too bad for the first 3 days, and I thought, well, if this is as bad as it's going to be, then okay, should be okay. But actually, as the week went on, I felt worse and worse and worse. I developed terrible muscle pains, joint pains. I was exhausted just on minimal exertion. Even walking up the stairs, I was getting short of breath and having to lie down for a while afterwards.
Just on the subject that we were talking earlier, I spoke to one consultant in Swansea yesterday who said the worst thing is for patients who are in the later phases of their illness, where they can't have visitors around the bedside, and that's heartbreaking for staff and for families, he said, when these patients are on their own during the last hours of their lives.
It's awful. And it completely flies in the face of everything we've ever done. A lot of patients will not survive intensive care, even, not in the middle of an epidemic. And we are very used to providing a good environment for people to have a comfortable and peaceful death with their families around them. And we have psychologists, we have excellent nurses who are specialists in end-of-life care. And we, although it's a high-tech environment, we can provide a really peaceful and compassionate end for people, and we really pride ourselves on that. And this is completely disrupting our ability to deliver that. And no amount of video calling or phone calling can make up for that. And that's something I'm very worried about. I mean, we're very lucky that we haven't had many deaths at all yet. Our intensive care strategy is working. But in coming weeks, this is going to be a huge, huge problem. And I'll have to be honest, it's not one that we've cracked yet. The sensible thing to do is to keep people away. Yeah.
How are you feeling about that?
There are a huge number of things that are not normal about this situation, and that's one of them. And I will do my level best. The one thing we can do, and that we are able to do, and that I will do, is we can, even if the patient's family can't come in, is we can be there. You know, a doctor will be there, a nurse will be there, our team are very caring, and I will, you know, if necessary, we will sit with those patients and hold their hands. And no one should die alone, and no one should die without someone holding their hand and talking to them. But ideally it would be the family, but as I say, at the minute we haven't quite got to the stage that we can facilitate that.
Are you envisaging a moment where you might have to ration healthcare in a worst case scenario?
At the moment we've got sufficient capacity to deal with the demand. But as weeks go on, if we don't see a slowing down in the infection rate and we don't flatten the curve, then we are going to start running out of space, and that's when very difficult decisions are going to have to be made. I hope to God that I don't have to do that, but it may happen, and we've seen it happen in Italy as well.
Access to ventilators, for instance? For
instance, yeah. But it's much more than just ventilators, it's staff as well. So there will be enough ventilators of one shape or form, but you need a whole gamut of staff, at least 5 staff, to safely look after someone on a ventilator.
And if you don't have,
that's the big problem.
If you don't have that resource in terms of staff available,
if you don't have enough staff, what happens is that your outcomes start to get worse.
Can I ask you what your message to the public would be now? From your perspective, inside this unit?
My 2 messages to the public at the minute would be, 1, keep doing what you're doing. Please support the NHS. We really, really appreciate it, and it's all the thanks we need. But the other thing that's massively important is please listen to government advice on staying in. Don't go out unnecessarily. Don't pop to the corner shop just to buy some milk. Please adhere to the advice, because at the minute we've got things just about under control. In 2 weeks' time, if infection rates rise even further, this is going to be a very, very different situation, and it's going to be very frightening, and people really need to heed that advice and be aware that you can get this at any age and any degree of health. Don't think that you're so young and healthy that you won't get it, because we've seen people again and again developing this illness when they've had no medical problems before at all.
You've been working in the NHS for how long?
20 years.
Do you think that this particular experience will change you?
Yeah. I don't know how yet, because you never know in the midst of it, do you? But I think it will change. I think it's going to change the whole world. But I think that it will change the NHS massively in terms of the way we do certain things. I think the NHS will become more efficient in some respects.
And what about you? And what about your view now on the profession you joined?
Oh, that hasn't changed. That hasn't changed. You know, I joined intensive care to save people's lives, and that's what we're going to continue to try and do.
I just wonder if you have a message to the families of those who are in this unit and who perhaps can't be with their loved ones.
Yeah. And I can't imagine how awful it must be to not be able to sit with your family members when they're this unwell. Please believe us when we say we will do absolutely everything we can to get them through this, and we understand how difficult this is. Please bear with us, but the one thing I can absolutely promise is, irrespective of what happens to your family member, we will always be there, and we will always do our best to make sure they're comfortable and that they're not on their own. We are all there, and this is the reason we chose this job, is so that we can, give comfort to people who are critically unwell, and we'll continue to do that.
I mean, you're immersed in this, in the midst of this outbreak at the moment. How are you feeling at the moment? Emotions?
Emotionally, we're very, I guess it goes with the territory. You become very good at putting these things in a box. They all go in a box somewhere, and one day they'll come out of the box, but now's not the time. So we'll address that when we come to it. But at the minute, it's just to focus on the task that we've got at hand, which is an absolutely Herculean task, to be honest.
What are you finding currently are the most difficult decisions that you're having to make in the unit?
As I say, so far, because we were very, very aggressive very early on in the outbreak, that we have still got capacity to take patients who will benefit from intensive care. We haven't had to make any decisions based on availability of equipment, and I am dreading if we ever get to that stage.
What do you find the most striking difference about treating patients with this virus than you would normally be in an intensive care unit role?
The biggest thing is lack of contact with people's families. That's the one thing that is really playing on my mind, and it's the one thing that I know my colleagues are very worried about as well, is that we don't just treat patients, we treat patients and their relatives and their families, and we provide them with support, and it's very, very difficult to do that remotely. I think that's got to be our biggest worry. I mean, all they can do at the moment, relatives of patients we've got, is trust us that we will do everything that we possibly can. Don't listen to adverse media reports talking of rationing or lotteries or people making the cut to come into intensive care. If your relative will benefit from intensive care, we will bring them in. But that's not to say that we will bring everybody in, because some people will not benefit, and that would be the same if we didn't have a pandemic.
Do you think you're going to weather the storm here?
I hope so. I hope so. It really depends on the next few weeks. If you look at I've seen some of the public health projections, and there are two sets. There's a set, if we flatten the curve, I think we will deal with what comes in, as long as we can keep patients flowing through the hospital and get them out when they start to get better. I think we will weather the storm. Particularly if the public ignore distancing advice and people, this is going on for a while, there may come a point where people think, actually, do you know what, I've had 2 weeks at home, I'm going to start venturing out again. If that happens, the rate of infection will rise again, and we cannot take another spike in infections. If we can flatten the curve, we've got a chance.
What would that mean for you here, do you think?
Well, that would mean that we would run out of space, we would run out of staff, we would run out of equipment, and we will have to, the rationing that you spoke about will have to happen. And that's the one thing we don't want to happen. If people get bored and they leave the house and then the infection rates start to spread, it will be like a wave, and it will wash the hospital away. And the fallout from that will be absolutely catastrophic, and I can't emphasise that enough.
It must be particularly difficult for you and your colleagues, seeing that quite a few NHS workers have died from this now.
Yeah. It's absolutely terrifying. And again, it's a reminder that, the NHS staff, there is a reason why we all do this, and there's a reason why people are willing to risk their lives to look after patients with coronavirus. And it's because that's what we all signed up for. But it's the last thing anyone wants to see is healthcare workers losing their lives. But again, it's a reminder that the virus does not discriminate on your status, on your age, on your job title. And actually, it doesn't care that much whether you've got pre-existing medical conditions. Some of these healthcare workers are fit, healthy people, and that's absolutely, that's terrifying. And I think that everybody who's working here would try not to think about that too much, but everybody's aware of it, which is why we're being so obsessional about making sure that we, check our PPE, check each other, keep each other as safe as we can. But I'm afraid that won't be the last of it. We will see more healthcare workers dying of this.